So turning to our speaker, Dr. Atkins is the executive director of the PROUD Project, a bilingual charitable nonprofit which conducts research and advocates in the area of health equity, disability employment equity, and anti-ableism. PROUD produces a podcast, Broadcastability, a podcast by and for and about people with disabilities. The Institute is associated with the University of Toronto Scarborough. It receives funding from Social and Development Canada, the Social Sciences and Research Institute, TechNation, and private donors. Dr. Atkins holds a status-only position in the Department of Political Science, University of Toronto, and is on disability leave from the Faculty of Arts, University of Calgary. Dr. Atkins has a PhD in political theory from the University of Toronto and a postdoc in law from Cornell University. She publishes in medical, legal, and social science journals about disability, bioethics, health equity, anti-ableism, human rights, and narrative scholarship. She's authored My Imaginary Illness, which was awarded the American Journal of Nursing Book of the Year in 2011, 2011 May Cohen Lecture in Women's Health, Faculty of Health Sciences, McMaster University, 5th Annual Sue McRae Lecture on Ethics and Patient-Centered Care, University of Toronto. She's held Shirk, Clark, Fulbright, and Killam Fellowships. Without further ado, I pass it on to you, Dr. Atkins. Thank you again for joining us.
Thank you so much for having me, Michael. I'm very grateful to be here. I was actually explaining to Michael before we started that I'm going to do a bit of a trick that most of my mentors did, which is I've been thinking about this topic and I'm trying to formulate a paper about it, how it came about, and I'm really hoping actually that I move through the slides relatively quickly, like obviously not so that I'm a speed demon no one understands, but so that we can get to a discussion and I can hear your views and thoughts on it, because that's always incredibly helpful. I thought about doing this paper and actually I'm going to do it with a clinician. But I underwent a stem cell transplant for an autoimmune disease, a chronic illness, which is relatively rare in Canada. And one of the things, it is now being spread as a practice across the country. But when I was asked by a team in a larger, so I did this in Ottawa, this I think in a larger city, they sort of asked me about how it worked and how the team members worked when I was undergoing the stem cell transplant. When I explained the team, they just said, "Oh, well, that's not going to work here. That's just not going to happen." And it was really about the way people communicate, the way the teams are formulated, the sort of professional courtesies and boundaries that exist. And so it began to get me to think about how we might change that, particularly for people who undergo chronic illnesses, because they, in a sense, have or should have a longer understanding of illness, of their own illness. So who am I? Actually, Michael's already said this, so I won't perseverate and go over it again. Um, I the reason why I actually have a neuromuscular disease and the reason why I'm on a disability leave is I can no longer breathe at altitude in Calgary. And it is freezing cold in my office right now. We're having a storm here, and which is why I'm wearing a cap. So forgive me. All right, so what I hope to do today is I'm going to present two case studies a little bit differently, but about two people with chronic illness who I see that there's sort of problems with the way information was communicated, and I think it affected care. And I'm really intrigued as to how we might change how that information is communicated, both amongst medical team members, like healthcare team members, as well as with patients and their families. So the first, I have a presentation of one case, and I'm going to sort of lay out a clinical view of what that patient looked like, I think, really in the system and the way the family saw it. And then sort of my concerns or thoughts about that case. And then I'll present a second case. And again, I'm doing a little bit of the clinical versus the patient view and some concerns regarding that case, and then just an open discussion of both case, and I hope by all of us about how some of you might think things might have gone differently or better, or maybe I've got something wrong. So the first case is a case of non-alcoholic fatty liver disease. So a 67-year-old woman arrives by ambulance at a local ER. Her family reports her having fallen twice in the past 24 hours. They also report that although she was previously obese, she has lost considerable weight and has had increasing falls in the last year. She has type 2 diabetes and takes multiple medications to control her sugars. She does not follow a diabetic diet. She remarks, I want to eat what I want to eat. Um, she is admitted to internal medicine with a large hematoma on her torso and legs, and she is severely anemic and has low platelets. She requires 2 units of blood. A head CT scan shows evidence of a right hemispheric brain bleed. An endoscopy reveals esophageal varices. I'll explain those in a minute for those who aren't medical. Physicians make a diagnosis of non-alcoholic fatty liver disease, a sequelae of her poorly managed diabetes. Once she is medically stable, she is transferred to a unit within the hospital to wait transfer to rehab. She stays for 1 week and then goes to rehab. After 2 more weeks in rehab, she is discharged to a retirement home with 5 hours of community home care a week, which really wasn't enough. And then she apparently had a follow-up appointment with the hematologist in 6 weeks. And I've since learned that she had multiple falls while in the retirement community. So likely wouldn't have been able to stay. Gonna move on. So from that was, oh, let me go back. What have I done here? Yeah, so that's really what I would say. Did I do a clinical perspective? Yeah. Okay. So one of the things that I noticed here is that this woman was very effectively managed. She was medically stabilized, and she was moved through the system very effectively in the sense that she was stabilized. She was then moved out of an acute bed and then transferred onto a less intensive bed and then moved into rehab. She had that for 2 weeks and then she was moved into a retirement home. I think the province paid for a month or two of it, and then it was going to be up to the family to take it over. So in some sense, she was very successfully moved through the system, and there was little delay in those movements. But I don't think her treatment was great. And we'll go to what her family's view was. From her family's perspective, their 67-year-old mother and sister is recently retired as a business analyst for a major insurance company. She's undergone substantial changes. The patient, Adele, has two adult children. One is a lawyer and the other is a certified public accountant. Her sister is a physiotherapist. Her husband has a long-term brain injury and requires a daily regimen, which means he does not visit. The patient has been the sole breadwinner and caregiver in the family. Adele now has intermittent slurred speech and word finding difficulties. She has poor short term memory and says, no one consults with me. My children are trying to take my money. In fact, the children do consult with Adele and note that down any appointments on a calendar and whiteboard, she simply does not remember the interactions and she cannot read anything without assistance. Her writing is illegible. Her sister notices that Adele struggles to feed herself. The physio identifies a lower left visual field problem after Adele complains that the spoon, quote unquote, disappears when bringing it to her mouth. The family requests a more thorough perceptual assessment and a neuro and hepatology consult. Adele continues to fall on a daily basis and has cognitive and memory issues. She remains disoriented in terms of time and shows impaired reasoning. She often denies that she has liver disease, stating that just because it's written down doesn't mean it's true. Um, so their view of things was quite different in the sense that um, their mother was moved through the system quite effectively, but no one really spoke to them about what I said I would explain esophageal varices. From what I understand, I'm not a clinician. When a liver fails, what happens, it hardens and there's sort of a hypertension that develops in the blood vessels leading to the liver. And these are subsidiary blood vessels that develop to try and to bypass those sort of difficult to move through vessels. And they're very prone to bleeding. And they're not enough, really. I had never realized this case was new to me in the sense that I had not realized. I knew that diabetes could cause blindness. I knew diabetes could cause nerve damage, and therefore you could have problems with your extremities, and you could have amputations. I had no idea that sort of poorly managed diabetes could stress, that the spillover of toxins could spill over to the liver, who then sort of becomes overtaxed, which then becomes overtaxed, and then from what I gather, will spill over to the kidneys as well. So the pancreas fails, and then the liver has trouble. And the reason why she's confused for some of it is that uh, she is sort of got toxins floating around in her brain now, and it's making it difficult for her to think. But the other part is she obviously had a bleed at some point. The other part of the liver failings, you don't make platelets, and so it's very easy for you to bleed and not actually clot. Um, but as I said, I think the difference between these two was that the clinicians sort of felt that they had stabilized the patient and successfully moved her through the healthcare system. So I just thought I'd put them side by side. For the clinical view, there was a head CT scan, a full body MRI, and endoscopy that was going down her throat, and that's where they found the esophageal varices and a liver ultrasound. They did a blood transfusion, a couple of them to make her more stable. They did an iron transfusion. She then was eventually saw rehab, was in a rehab bed for physiotherapy and occupational therapy. She was transferred, as I said, to rehab and then transferred to a retirement home and eventually transferred to a hematologist as an outpatient. From the family, they uh, they got Adele to sign a delegate power of attorney. She'd always wanted to do this. They just hadn't finished it and appointing her children as delegates. Um, the family asked for further investigations. They felt as though they had been told that she had fatty liver disease, but they didn't really understand what phase it was, what her prognosis was. Was she now going to comfortably live for years with this as long as her diabetes was managed? What was the future potentially going to look like? No one spoke to them about it. Um, and they also wanted to sort of understand if they could, whoops, I went back. Let me just go back. Um, Sorry, now I'm jumping around. Sorry for there we go. Um, was their mother's cognitive status that she was a very, very bright woman and she'd been a mathematician, and they wanted to sort of understand whether there was anything that could mitigate some of the confusion and the loss of cognitive function, or whether it was sort of going to be stable. It didn't seem to be stable, so that's why they had queries. I'm going to leave it there. I hope you want to think about that, and then we can talk about this case. Yeah, I worry about it a bit. Um, so what is the state of Adele's cognition? The other thing that I wondered about, does Adele have the capacity to consent? Like, does she have the capacity to consent to her own medical decisions, to her finances, to where she was going to live? She certainly wanted to go home, from what I gather from the family. Uh, and she did, as I said, she had moments of real lucidity. So I do know that there's lots been written about, you can have competence for one thing, but not another. But it was interesting that, according to the family, that the loss of cognitive status was a real, like her cognitive confusion was not really spoken about. And when they asked questions of clinicians, no one really responded to them. They sort of were evasive. So the aim of the acute medical team was to get medical stability and to make sure that the inpatient stay was no longer than it had to be. The family really wanted to know what Adele's prognosis was and whether there was any way that they'd be able to stop Adele continually falling. And they were trying to figure out whether they should renovate the family home, whether they should continue the retirement home living with extra help, or that she was going to end up in long-term care. They just had no sense of what clinicians thought of this individual. They'd never heard of um, non-alcoholic fatty liver disease, and they'd never heard of the encephalopathy that was coming alongside with it. All right, so this other case is actually me. So this happened to me this past month. Forgive me for doing this. I'll read it out. Again, quickly just really made me think about how teams function. I got really good care. I'm not complaining about my care, but it made me think about how systems function. So a 6-year-old woman, Flo, was elected to have spinal surgery for right leg sciatic compression. She has a severe and rare form of myasthenia gravis for 30 plus years. Flo recently had an autologous stem cell transplant to treat the refractory muscle disease. The MG has been pushed back. However, the patient has a long history of needing post-surgical intensive care due to myasthenic crisis. Flo warns the surgeon and anesthesiologist that she may have physical, visual, ocular, and respiratory weakness post-operatively. Further, she remains immune compromised, and decades-long use of steroids prolongs healing, so that my healing is very, very slow, and my tissues are very frail. Um, the surgeon nicks the dura during the operation and glues and stitches it shut. Post-surgically, Flo was admitted to the ICU with weak respiration, requiring plasma exchanges and respiratory support. Venous access is difficult, and the intensivists decide to place a femoral line, which is a line in the groin, for ongoing plasma exchanges. And unfortunately, Flo gets two deep vein thrombosis in the leg with that line. And 4 days post-operatively, post-surgically, the dural nick opens up and leaks ribosputin into the body cavity and then saturates and opens the wound that had been sealed on my and flows back. A spinal drain is inserted higher up in the dural sac to divert CSF away from the now resutured wound, and an unrelated contusion also became infected. So after 20 days in hospital, Flo leaves uh, God, I can't see. Now, I left after 20 days. So what was interesting about this case is I have many times tried to explain to someone with a chronic illness sort of the various things that can happen and what we can try and do to mitigate them. And I, every surgeon I'm going to give this guy a lot of credit, because every surgeon that I've ever encountered, they come to the door in ICU and literally I can see them blanch. And from then on, I just see their residents or I see a fellow. They never ever talk to me again. I think it's just shitty. They just don't anticipate what I know is coming. So this guy was really good. He came in about on the fourth or fifth day and he just said, I did not take this seriously enough. And he said it twice. I did not take this seriously enough. What I've wondered is, what could I have said without sounding hyper melodramatic and sort of, yeah, hyper melodramatic, to him and the anesthesiologist. I think the anesthesiologist understood it a bit better so that he was more prepared. That, what I thought when he came into the ICU and told me that he had nicked the dura and I was on respiratory support and not, I mean, I knew I was going to get better, but part of me was thinking, I am not the patient to have nicked the dura on. Like, more care should have been, in my head, I'm thinking, if possible, more care should have been taken. Like, we should have been really careful. And I had no idea what could go wrong, but in fact, it did go wrong. So um, I wondered about how to do this. Now, the other thing that I found interesting, and always do, is that you have in the hospitals an ethos and bioethics of equality. And rights. So the patient has certain rights, they allow, and they have to consent and all these things. But nonetheless, as a patient, you're being slotted and hitting up against a very hierarchical system. And so, particularly on a surgical floor, actually, I think it's maybe even a bit stronger, is that, you have student nurses and then you have their supervisors who are the nurses. You have, residents, and then you have the fellows and you have the doctors. And actually, on this unit, they had a nurse practitioner who was sort of the intermediary on another ward that I was on, another unit I was on. They had actually GPs acting as sort of the intermediaries to put fires out on the ward before the specialists had to be bothered. But one of the things I found in all of this was it was a very complex situation in the sense that I required I had clots. We needed to decoagulate me, but I had open wounds that needed healing. And those two were in conflict with each other. And as a result, usually I was in neurosurgery. Neurosurgery had to call neurology. Neurology then had to call the head of the apheresis team. Those are the people who do plasmapheresis, to say that I required apheresis. Then had to call back to neurosurgery to ask, because I use whether the anticoagulants used in plasma treatment were okay, given that the back had opened. And then there was then there was infectious diseases because I had an infection and just a wound I had gotten just, happened the day before I had surgery. It was minor, but it didn't become minor. Um, and I began to realize like and the team had probably, I think, three group meetings, like visual, because there were so many things that before anybody could move. What I found interesting is I was never invited to any of those meetings, though I was really consulted quite regularly. But I think it would have been helpful if I had been there. I think things might have moved along a bit faster. Um, so let me just move this back. All right, so it's a very short, good, it's short. That's what I wanted because I'd really like to hear what people think of both the first case and the second case, and to ask me questions or anything. This is where you can find me. And these are some of the websites that we maintain at the Proud Project.